right. Well, good afternoon to everybody. Hope everybody is doing outstanding so far on this Monday. We are really excited, Sarah and I, are to talk to you about this final OSHA ETS webinar. I know it's the most riveting topic possible, right? But it is one that unfortunately we have here to deal with. So we wanted to provide sort of a summary of sort of three big areas really on record keeping, HVAC, and also reporting best practices. And so that's what we're going to be covering today. As always with our programs, if you've got any questions whatsoever, we'd invite you to drop those in the chat. I'm going to be going first, so Sarah will sort of watch the chat for us, and then when she's talking, I'll watch the chat, and then we'll make sure that we address anything as we go along. Just important CE information, we offer credits for today's program, so make sure that if you are on your phone only, if you can drop your name in the chat box, we will capture it that way to make sure that we knew that you were present here. You will receive an email from Terry Goodman and Associates. It'll most likely go out tomorrow or the next day, but you should definitely have it within 72 hours that allow you to claim your CE credits. The way that will work is when you get your invitation, go ahead and complete that evaluation. At the very end of that, you'll be able to download your PDF certificate for your nursing records, and that way you'll have it for your continuing education. Just quick introductions in case you don't know me and Sarah. I'll let us introduce ourselves here for just a second. My name's Hudson Garrett. I'm an adjunct assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine, and really excited to be presenting with my good friend and colleague, Miss Sarah. So Sarah, do you want to quickly introduce yourself?
Sure. My name is Sarah Bishop. I'm a clinical nurse specialist with the University of Louisville Division of Infectious Diseases, working in the Center for Education and Training and Infection Control.
Awesome. Perfect. We're glad to have you there. And just as a reminder, if you are not able to download that certificate, you'll be able to send my team an email and we'll be able to handle that for you so that you can get that taken care of. Since we're offering continuing education credits for today's program, you can see financial disclosures for myself, and Sarah does not have any. And really our objectives for today are to look specifically at sort of this last part of that OSHA ETS. If you joined us for the last two programs that we did, great. If you did not, certainly would invite you to go back and look at those recordings that are available on our YouTube channel. We'll talk specifically about record keeping, some of the anti-retaliation, and then also Sarah's going to give a great overview of probably the most important topic, which is ventilation. I think we can all agree that ventilation has been an area that many of us try to stay away from as much as possible because it's such a confusing area, but certainly one that has a lot of relevance in today's discussion. So it would certainly be kind of crazy if I didn't mention what happened last week with this new mandate. And obviously there's multiple different pieces to this, but I wanted to focus in, excuse me, for just 1 second on the vaccination mandate. And so this is going to be forthcoming through CMS, right, for all of the facilities that receive that federal CMS funding. And so I put a list there as well, and there will be a public comment period sometime in the month of October. And so we'll be watching that very carefully. And then of course, our private businesses got some, interesting news late last week as well regarding some of the vaccine mandates or testing mandates. So lots of things I think will be happening over the next few months. And so you probably will be hearing from me and Sarah again very soon regarding some of those other issues as well. But I wanted to start again with sort of that definition of that high-risk exposure, right? And this is directly pulled from, really how CDC and OSHA interpret this. But think about the different types of risks that we as healthcare workers are exposed to on a daily basis, right? Normal patient contact, walking in and out of a room, really much lower risk. Aerosol generating procedures, totally different scenario. There was even a study that was published last week looking at emergency medical services and sort of their overall risk for contracting the SARS-CoV-2 sort of, virus, and then unfortunately getting COVID. And it was actually pretty low when PPE was appropriately used. And so the good news is that when we appropriately manage these scenarios, we know what we're doing, we limit the amount of people in there. These are all things that are going to help us sort of mitigate those occupational exposures. So as we mentioned before, right, we're taking sort of that final dive through the last few parts of the OSHA ETS. Now, what'll be interesting is sort of how long this stays in effect. And then when do they transition it away from an emergency temporary standard to more of a permanent standard and really go out to that public comment period? If you've looked at the American Hospital Association sort of summary on this, there's a lot of interesting commentary in there about, this is almost a day late and a dollar short, right? We were doing many of these things before, as we've talked about, but there are some things, particularly with what Sarah's going to talk about with ventilation, that we really want to pay attention to, especially in some of the areas that have very poor ventilation so far. So I wanted to start quickly with an overview of sort of the training program elements and what we need to have in our training programs. This is going to help us sort of understand the record keeping perspective, as well as how do we report things and what time frame do we need to do that, right? So if we think about basic elements of training for our staff, first of all, we got to know who we're training, right? Is it a nurse? Is it a physician? Is it an environmental services worker? Who might it be? So certainly we're going to start with that basic element of what is this disease and how is this virus even transmitted? Is it truly airborne? Is it more droplet? Do we need to wear a gown? What about gloves? All those types of things, right? So sort of that basic pathophysiology and epidemiology of the transmission. The second piece is really going to be dependent upon us, right? Maybe you're working in a primary care office versus an acute care hospital. Totally different risk, right? We know that the procedure is going to be different, the resources will be different. And so that employer specific policy and procedure is going to be really, really necessary to sort of think about as it relates here. The sort of third one is thinking about what types of care do I provide in my particular facility? Am I somebody who is in urgent care and I'm going to be doing lots of aerosol generating procedures, as an example? Am I an EMS unit and I'm going to be doing lots of aerosol generating versus maybe your primary care clinic or even somewhere like a blood bank, as an example, that's going to do something completely different, right? That risk is going to be different. My procedures will be different and my interactions will be different. Sort of the fourth one is really looking at workplace specific policies that prevent spread, right? So I sort of laughed at the very beginning of the pandemic and I'd walk into all these nursing homes and they'd all have this plastic tarp coming down from the ceiling. And lo and behold, almost every place I went, and I went to probably 75 different nursing homes, none of that tarp was completely sealed. There was always a hole at the top. There was a hole in it. It was left open. And then I would ask the really important question, and Sarah's going to laugh when I say this, of, is this whole unit connected to the same air handling system? And they would look at me and they'd say, I don't know. And I think, well, if it's connected to the same air handling system, how is this little piece of plastic tarp really doing a lot of good, right? And so we've got to think about sort of the delicateness of addressing some of these scenarios with recommendations that might come out. You may also have people that work in different places, right? So you may have somebody who is part of a health system and maybe they work in different places. They do use shared medical equipment. Maybe they have equipment that's couriered back and forth. So we've got to account for that. What about PPE? Right? We talked about this in the last two programs, but PPE does have limitations, right? And it is also our last line of defense. And so we want to sort of prioritize, how do I sort of engineer that risk or eliminate that risk and use PPE as sort of that last line of defense. Of course, PPE is only as good as we wear it. And I, am still convinced that people do not understand fully the respiratory system, that the nose is connected to the throat and it's going to be connected to the lungs. And so when that mask is worn below the nose, it's really not being nearly as effective as possible. And then you're going to also see some recommendations in the training program about sort of, what are we doing for cleaning and disinfection? How do I keep those really high touch surfaces as clean and disinfected as possible? And remember that the EPA has actually published List N, which gives you an idea of the commercially available disinfectants that are already EPA registered out there that will take care of the SARS-CoV-2 virus with no issues. Now, one of the things that you'll see in here is sort of how do we deal with employees that have an issue, right? So maybe I have an employee specific or an employer specific policy that addresses how I'm going to screen. What am I going to do if this individual contracts occupationally COVID? Am I going to put them out on some type of specific disability? How will I address that? Can that person telework? All that type of thing. And then who's my safety coordinator that's, again, going to have the authority, but also the basic knowledge to really implement this program and work throughout the facility to remove barriers, to sort of remove those obstacles and make sure that everything takes place, right? And then lastly is, how can that employee actually obtain copies of our plan? right? And we don't want to give them a 64-page plan. We want to give them something that's going to be useful, some good, workforce tools or job-specific tools that will help them be safe in their particular role. So every time we think about a training program or even getting to record keeping here in just a second, we got to start with sort of the first step, right? Who is our target audience? Is this an audience that's all highly skilled master's prepared nurses? Is it physicians or pharmacists? Is it healthcare executives that are not clinical at all? Is it a group of nursing assistants or maybe an environmental services team? And I want to use environmental services for the example here because they represent such an important part of healthcare, but they also are an extremely diverse group. Right. So we know that very frequently environmental services, English is not their first language. And so we need to think about that carefully and say, are the tools that I'm developing, going to be at the right sort of reading level and sort of, level to sort of transmit that information and transfer it, but also, am I doing it in the right language? If 60% of them prefer to understand everything in Spanish, right, that's their sort of native language, then we really need to consider that. Should we have a translator? Can we get the materials translated if that's going to be helpful for them? What can we do that's pictorial? So it's got to be all specific to that particular job role and the needs of that user group. So you may find yourself sort of having a nursing group, a physicians group, an executives group, environmental services, et cetera. But think about sort of how do I make those training materials as relevant as possible? The other thing that we have to think about is a way for them to honestly interact with us. Let's say that you got on a webinar and there was no way to ask questions. Let's say that Sarah and I just said, bye, we're going to sign off now. We got to go. Sarah's over there laughing. We would not do that, right? That's not the whole point of this series. It's really to give you an opportunity to ask questions, to voice concerns, to, get clarity around particular issues. And we've got to do the same thing when we think about training. Right? There's no way possible that we can actually train if we don't assess training and we don't give that person an opportunity to ask questions that are really pertinent and relevant to them. And a lot of times people will start, well, I don't want to ask a stupid question. There are no stupid questions. The only stupid question is the one that's never asked, right? Because as soon as you raise your hand or ask that question, 10 other people probably had that same question and just to want to ask. So an interactive training opportunity is really what we want to try to do as much as possible. Now, that could be virtual, like what we're doing now with Zoom. It could be in person. It could be some type of interactive recording where maybe there's different competency assessments throughout there. So there's a lot of different modalities that you could use. OSHA is not going to specify what you have to do. However, let's say that you are doing something like what we're doing right now. So you have Sarah and I on, we're live. This is not a recording, is it, Sarah? We can verify that we're actually here live, right? She gave us a thumbs up. So we're actually here, right? But when we do virtual type training or CBLs or some type of learning management system, you've got to have access live to that trainer that has the information so that you can ask those questions. That's a really important piece. So you can certainly put everybody in an auditorium, let them watch a video, but then at the end, bring that trainer in, and that way you have that opportunity. So what about sort of the aspects of frequency, right? We often talk about, well, let's train at the time of hire for sure, right? Let's train at least annually, and let's certainly train when a process changes, right? But there may also be sort of documentation or trends that say, hey, we've got a particular problem with people properly using their mask, as an example. Or we have staff that we've told to use a gown and they're not using a gown, so we need to readdress that. So training can also be ad hoc to allow people an opportunity to sort of get a refresher, right? Very much like what we do with CPR. If you don't use BLS skills or ACLS, you lose it, right? So you want to have that sort of, quarterly refresher if possible. So, certainly think about employees' risk. And if we're seeing trends that document, hey, we've got a potential issue in this ICU as well. So transparency, right, is an important element of this. And it really is sort of core and fundamental to much of what OSHA does in general, right? OSHA is huge, and rightfully so, about protecting the reporter. So let's say that Sarah says, my workplace is unsafe. I don't feel like I can work here. I'm having asthma issues in the building, and she reports it to OSHA. And then the university says, Sarah, you shouldn't have done that. That was really, really bad. We're going to have to fire you because you caused us a lot of issues, right? That would be completely unacceptable and actually illegal, right? Sarah is a protected person as from any type of threat of retaliation. So because she's in good faith reporting that information, right? Ideally, she would report that to the employer first, and then the employer didn't do anything. Then, certainly you have the right to go to OSHA with that. And OSHA takes these types of complaints very, very seriously. Right. We also would hope that employees would sort of self-police some of this stuff. So if we're seeing a coworker, if I see Sarah doing an aerosol generating procedure and she's not wearing the proper PPE, I'm going to walk in there and say, hey, Sarah, can I bring you that PPE that you need? Right. I'm going to try to instantly correct it as well. So Nicole, I see, had a question. What would you recommend for retraining when you notice an overall trend with mask non-compliance? Excellent question. So there are a couple of different training tools that are available on the CDC's website. Many of them were actually produced back during Ebola as well. So I'd encourage you to probably check those out. But honestly, and I'll let Sarah sort of chime in here, the way that I like to do mass training is I like to do hands-on. I like an opportunity to sort of give them an idea of how quickly they can become contaminated. There's some great data out there with some good pictures about sort of the petri dish look of, hey, if somebody coughs or sneezes and everybody's masked, here's what it looks like, right? Which is pretty non-existent versus if somebody's not wearing a mask as well. The other thing you could do, and I've done this before, is use glow germ. And sort of I don't tell the person that I'm going to contaminate their mask with the glow germ powder, but then I do. And you can see not only if they're properly wearing it, but also if they're touching it and stuff like that, how quickly their hands become contaminated. So Sarah, I don't know if you want to add anything to that.
Yeah, I'll just say, and sometimes it's helpful to assess, is it a knowledge issue or is it a compliance issue? And does there just need to be a little bit more accountability or understanding why maybe the individuals are not being compliant? Do they not have access to the PPE they need, or is it just something that maybe there needs to be accountability? So
perfect. Yeah, I would agree. I mean, a lot of times we do have knowledge gaps for sure. And then, that also makes us question our training, right? Was our training effective, and was it really appropriate for that audience? So let's say that we go back to that example and Sarah gets terminated for doing the right thing. She reports this unhealthy condition. She's reported it to her employer. They did nothing. And now multiple other people are getting sick, right? And the university turns around and says, hey, we're going to terminate all of you because you reported this, right? There are specific protections within the OSHA regulations that really protect the workers, right? They don't really have any interest in the employer, right? They're really regulating the employer, but there is good protection in there for whistleblowers as well as those that are in good faith, again, reporting this. Now, if you're a malicious, terminated employee and you go report to OSHA, that's not, if it's not well sounded and sort of, evidence-based in what they're finding, don't expect something to happen, right? This is not meant to be a sort of a grief tool. It's really meant to be a tool to sort of address true issues that might be there. So what about ways that we need to communicate this? And again, we want to document this all as part of our record keeping. Not only have a copy of our plan, but how we're going to communicate, when we communicate, sort of the feedback from our employees as well, right? So again, OSHA is giving you lots of flexibility as to what the modality is and what you do this. So, if you want to provide this in the form of a written standard, you can provide it in a staff meeting, you can put it on your intranet. Ideally, you would have a way to sort of validate that every person had received it, right? I'm a big fan of, did you receive, do you understand, and do you agree? Those are sort of three very different words, right, that mean different things. And so as long as that employee is there, that's going to be very, very, helpful to make sure that that's communicated as well. So what about records retention, right? So if you are one of those folks that falls within the 10 or more employees, right? So maybe you're not a small private office as an example, you're required to maintain and preserve that COVID-19 log while the ETS is in effect, right? That's just for OSHA, but certainly you probably want to maintain that longer than that. And then under the current CFR standard, right, for the OSHA 300 log, you want to maintain the 301 incident reports for 5 years, right, following the end of the calendar year for which these records cover. Again, a lot of organizations keep these permanently, and they can certainly be scanned and digitized as well. So the overall standard, right, is going to apply, it's going to apply to folks that are 10 employees or over. So if you're under that, if you're a small dentist office, and we've got a couple of those that have joined as well, not going to be covered here, but certainly your employees are going to have an expectation that the safe care would need to be there. The other thing to consider too is that it's really the total number of individuals that are employed in a firm. So let's say that you are part of a satellite, right? And you've got 10 of those across the state, right? And you've got a total of 500 employees, but you're all one entity, right? That's going to be counted as such. You also want to make sure you're considering your full-time, your part-time, your temps, and seasonal employees. I thought it was very interesting. And Sarah, I don't know if you sort of got a laugh out of this, but I thought, what seasonal employees do we have in healthcare, right? It's not like UPS where they, get the package helpers. So I really couldn't think of that. So Sarah, if you can think of seasonal employees, I'd love to know. I think we would all like to have employees in general. I'd like full-time employees, not seasonal employees, for sure. So what about reporting requirements? So again, if you think about that traditional OSHA CFR, right, work-related fatalities, have to be reported if a death occurs, right, within 30 days of the workplace incident, or if there's an inpatient hospitalization, then 24 hours of that work-related incident. Now, let's think about this sort of in terms of the ETS. Right. So if you have a COVID-related fatality, you have to report that within 8 hours of learning of the fatality. Very important words here, learning of. So if that fatality happened last Thursday, but Sarah and I only learned about it on Monday morning, then that is when our 8 hours starts. Right. So it's not based on if you don't know, it's based on when you learn about that fatality. Now, certainly OSHA expects you to have good systems in place to report that so that your employees have the opportunity to do that. If you have an employee that has a COVID-19 inpatient hospitalization, right, your time frame is 24 hours, right? So again, fatality is going to be 8 hours of learning. Hospitalization for employees is going to be 24 hours of learning. So at least they were smart enough to put the of learning in there, so it gives you a little bit of flexibility. Now, there are 3 different ways to report either of these situations. You can call your nearest OSHA office. I've included the hyperlink there so that when you download the slides, and if you didn't do that, again, I'll post them at the end as Sarah's talking. You can go ahead and sort of save that nearest OSHA office. You can call their 800 number. I'll tell you from experience that can sometimes take a little bit of time. The most efficient way is to actually do it via electronic submission, right? So again, I've included the hyperlink there so that you can save that if you don't have ready access to that in order to do that. So at this point, we're going to sort of switch over and talk about the ventilation piece. And as I mentioned before, our goal was to sort of walk through each piece of the OSHA ETS. As additional things come out, which we're certainly well aware, there's going to be more topics related to some of these interesting executive orders and how the timeframes of those sort of net out. We'll continue to schedule some more of these to bring you that hot information. But at this point, I'll turn it over to Ms. Sarah, who's going to walk us through the ventilation piece, and then we'll see some questions. And I'll go ahead and post those handouts while she's talking as well, just in case you didn't download them. Sarah, I'll turn it over to you.
Thank you very much. All right, I'm going to go over just a few of the key points here related to ventilation and the OSHA ETS. So first off, what is HVAC? It stands for heating, ventilation, and air conditioning, and it is the system used for moving air between indoor and outdoor areas and also helps heat and cool that air. So just if you're wondering what that acronym stands for, there you go. All right. So why is ventilation important related to COVID-19? Well, we know COVID is transmitted through respiratory droplets. So air and air movement and movement of those droplets throughout the environment certainly plays a role in how it's transmitted. And we know that there's numerous studies that have shown that people can more readily transport those viral particles indoors versus outdoors. So we're looking at what are additional tools in an indoor space that can help reduce that risk. But it's important that we recognize our most important tools in reducing the concentration of those respiratory particles and the virus in that indoor setting are still the basics of wearing a face mask. So when we're indoors, making sure that we are utilizing that tool, physical distancing, and then reducing occupancy levels inside an indoor space. So those are still really key elements to making sure that we contain the virus in indoor space. So what does the OSHA ETS specifically say about ventilation? So I've just, within these slides, listed the language specifically as they say it, because I think that's important, is that we can go back and we can read the ETS and know what do they actually say. So it's very basic stuff. Just says we want to make sure our HVAC systems are being used according to manufacturer instructions, that our outdoor air circulation and our air exchanges are maximized as much as we can. It also states we should be using MERV filters 13 or higher if it's compatible with the system. And we'll talk a little bit about what that means. Making sure that our air filters are maintained and replaced as necessary. All intake ports are cleaned and maintained and clear of any debris, so we can make sure we get the airflow in that we need. And if you have a facility that has existing airborne infection isolation rooms, that those are maintained and operated in accordance with their design and construction. So really the key components here are making sure that your HVAC system is working as it's intended. The ETS does specifically say that you are not required to install any new HVAC systems or airborne isolation rooms, assuming that those systems are functioning already. And then it does go on to state that in addition to those requirements, they do encourage you to consider other measures based on CDC ventilation guidance to help optimize your ventilation systems. And so there's a list of those things there, and we'll kind of go through some different elements. So that's what the ETS specifically says. So then next slide.
Do you want to go past this one, Sarah?
Yes, please.
Okay. And there was a question I just put in the chat to you that came in. It was, what if any documentation should we be keeping for HVAC system if all of the service and maintenance is done by an outside contractor?
So that's a great question. So what I recommend, so here is the ventilation checklist. So this is part of that broader checklist that OSHA has. What I would do, pull this out, regardless of whether you have employees at the facility that are maintaining your HVAC system or its contract workers. Identify who that key stakeholder, that individual is that is responsible. There's a place on this ventilation checklist to list their name, and I would connect with them. And I would go through this checklist with them to ensure that you are meeting each of these elements, and that that person who is responsible for the HVAC system understands the expectations, and you all work together. Because the fact is, we're not the experts, they are. And so by partnering together and going through this checklist and making sure that you all both understand the expectations, I think that that is going to be most beneficial. So I've got the link on here. It's on that main OSHA ETS COVID website. And it's within that checklist document that they have listed there. So that is my first recommendation. Figure out who that person is that's responsible and meet with them to go through the checklist. Okay. All right. So a little bit of information that might help you as you're going through this checklist and to know what the different elements mean. So what is a MERV rating? That stands for minimum efficiency reporting values. And it basically tells you it's a scale that rates a filter's ability to capture particles. So it's filtering ability. So this little table here is from the EPA, and it's kind of an overview of the different ratings, and then what size particles they capture and what efficiency they capture those particles. So the next slide has a nice visual of that. So, and can you click it one more time?
Yeah, sure.
There you go. So this just shows the size of each of these little elements and how many microns in size they are. So the MERV filter will filter down here through bacteria. One thing I do want to point out is we see coronavirus on here that's 0.1, 0.5 microns, and it falls outside of that filtration rate for the MERV 13 filter. However, we know that those little coronavirus viruses are not just walking around by themselves. They need a transport vessel, and so they're transported within the respiratory droplets. So the MERV filter is very effective at filtering, or the MERV 13 is very effective at filtering those respiratory droplets, which are larger. So I think that's important to understand why the setting is as it is. And you may find that based on your HVAC system, maybe a MERV 13 filter is too high and the system can't handle that filtration level. You have to use a lesser filter. But that's okay. You know, you need to make sure that your system can still function appropriately, and you just want to use that highest level that will work for your system. Again, that's why we need those HVAC experts working with us to help us understand how the system works and what is going to help and what may not help. So, but I like this picture because it gives a nice visual to the size of each of these little elements. So. Okay. Some other things. So we know heating or temperature and humidity play an important role in infection prevention and maybe, you know, an SPD, and we have our AAMI standards. And so you may be wondering, what about temperature and humidity when I'm looking at my HVAC system? So when we look at some studies, they do show that SARS-CoV-2 is sensitive to elevated temperatures. However, that temperature setting is well outside the comfort level for a human. So they say 158 degrees Fahrenheit is very effective within a couple minutes of clear or inactivating 99.9% of your SARS-CoV-2 viruses. However, I don't think any of us want to be sitting in an office or in a healthcare setting at that temperature. So because of that, the temperature should not factor in. You know, you just want a comfortable temperature, or make sure the temperature is in the range it needs to be for other recommendations. And then as far as humidity, we've got this nice little visual here that kind of shows us that optimal zone. And this graphic has been around for a long time, and these recommendations have been around for a while. So virus survival may be reduced when humidity is between 40 and 60% range, but the reduction is modest. So all that to say, neither ASHRAE nor CDC have recommendations for introducing any humidification for the sole purpose of limiting COVID-19 transmission. So really just maintain your temperature and humidity settings according to other standards that you need to for your facility and for comfort. All right, physical barriers. So Hudson kind of mentioned this earlier, and this is something else for us to take into consideration when we're looking at our HVAC system. So we may have a fancy filter and be getting indoor air in here and doing a good job with that, but it's only going to be as effective as getting our air distributed through the environment and back up into that filter and circulated. So one of the things we need to take into consideration when we have physical barriers is, could they potentially be impacting that airflow? So they could help, they could hinder, or maybe have no impact on that air circulation. So we just want to ensure that the barriers are correctly positioned for anticipated occupancy and are no larger than necessary to prevent, their intention is to prevent direct transfer of respiratory droplets. So if somebody sneezes, coughs, just they're a physical barrier to help protect one person from another from those splashes, sprays, from your respiratory secretions. So if you want to kind of evaluate to see if you've got some stagnant air pockets that have been created because of your barriers, you can utilize some different airflow distribution testing. Again, this is why it's really important that we engage our experts who are managing our HVAC systems, because they're going to be able to help us with this. And it may be something as simple as those little handheld fog generators, if you've ever used those or seen your maintenance or facility folks use those to maybe check for positive or negative air pressure to see if those things are working. Same kind of things that might be able to help us assess to see if we've got some stagnant pockets where we may not be getting that airflow moving around in the environment. So those are just some things to keep in mind. Okay. And then I just also wanted to mention there are numerous technologies now that are being marketed as air disinfection devices. CDC does not provide recommendations for or against any specific manufacturer or product. And there is a variety out there. So I think it's just important if you're going to consider one of these devices that you kind of do your background research on it. And if there is some peer-reviewed evidence available, that's really great to have to see about efficacy. Some of this stuff is newer or at least new to use in healthcare, so there may not be as much information out there on how effective it is. That doesn't mean that it may not work. It's just a newer technology. But one thing for sure you do want to make sure is that you evaluate the safety information. Because if this technology is going to be used in a space, an occupied space where you have, maybe even people with health conditions, you want to make sure that it is going to be safe and appropriate to use in that occupied space for those individuals. So look for that for sure. And some of the technologies generate ozone. And you can make sure, if that's the case, that they meet these standards here, UL 867 or UL 2998, to ensure that if there's ozone production, it's in a safe zone, or there's not that ozone production. So those are just some things to consider. And again, please collaborate with the individuals that are the experts that manage your HVAC systems and can help you kind of look at this together and walk through it. And so here's some great resources. CDC has this information on ventilation in buildings, a lot of great Q&A questions on there. Much of what I covered here is from their website. ASHRAE, which that's the American Society of Heating, Refrigerating, and Air Conditioning Engineers. They have a guidance document specific to COVID-19. And so that's a really great resource to look through. And then I also included the EPA link that talks about a MERV rating if you want to get more information on that. So these are just some good resources. You can go to the site, read all about it, and have fun with that.
Awesome. Perfect. So just a quick recap. I know a couple of you had asked about the handouts. I did post those again in the chat box for you right below Kimberly's question. If for whatever reason you don't receive those, not to worry, we'll send those out to you along with the recording. So a couple of you had to jump on and off due to some other responsibilities you had. So we'll make sure that recording is available to you. But really keep in mind that this is going to be an evolving process, right? Sarah just went through a lot of information. I went through some information. This is now our third webinar on one single ETS. And we're really not well accustomed to dealing with these sort of emergency standards in healthcare. They're a little bit few and far between, thankfully. But we recognize that ventilation is going to be a continued issue for us for sure. And a lot of this goes back to, how do I make sure that I exercise good judgment? And that is a skill that I find incredibly hard to teach people. So sometimes they sort of go and jump off a cliff rather than sort of take a step back and say, what are we really trying to accomplish? What is our goal here? And then how do we sort of best do that? So we do have some additional tools and resources available for you just in case you're interested in those. Again, these are all live hyperlinks, so you can download those off the handouts and you can click on it and it'll take you right to that particular website. Just as a reminder for continuing education, if you're a nurse and looking to claim credits, make sure that we had you either on the attendance list or you typed your name in if you were on the phone only so that we can credit you for that. And that invitation will be coming out through Terry Goodman and Associates, who is our CE provider. That should be coming out no later than Wednesday of this week because I go ahead and run the report here today. We will send out the recording, as I mentioned, as an email in case you want to share that with any other colleagues. And we'll also be posting that on the CTIP YouTube website as well. So with that, we'll stop and see if you've got any questions for Sarah or myself. And we'll be happy to stay on as long as needed to answer those questions. And if you want to unmute your line, you're welcome to do that, or you can drop it in the chat box as well. Wanda, thank you for that message. I got it for Mary Evers, so we'll go ahead and get that added for you. I know one question, and Sarah, I'll sort of throw this one at you that came up, was how long do we think the ETS is going to be around, right, before it transitions to a full standard, or do we think that it will?
Hudson, I don't know if I know the answer to that. I think we all agree. Yeah, I think we all agree COVID is probably going to be around with us for a while. So I think, you know, again, at the end of the day, this is all about protecting our staff. So these are elements that you know, we want to have in place to continue to make sure they're safe. So we'll see. We'll see what the future holds. I don't know if there's anyone on this call that maybe has some insights on that, but we'll just have to stay connected and see where things go. I do know that Kentucky, which Kentucky is one of 20 some odd states that have our own state-based kind of OSHA group. I know they did send out some information recently on an opportunity to kind of ask questions of a public comment period right before they adopt this. I don't think that they're planning on any additional requirements above and beyond the federal OSHA ETS here. But I think we'll stay alert to that and be sure to communicate to the group if there's some additional requirements that come from them.
Yep. I know another question that came in regarding the vaccine mandate. So, you know, they are stating that there's going to be sort of the final rule with proposed rule with public comment out in October. I was personally very pleased to see public comment. I think that's really necessary for any of these types of items. You know, the more that you sort of input into that process, hopefully the more that OSHA and CMS will listen. Because there are going to be some nuances associated with that. I met with a very large business actually last night. You know, that's a multinational company, and they're thinking, how in the world am I going to implement this testing if I have employees that refuse to get vaccinated, especially when testing supplies can be increasingly hard to get your hands on. So there'll certainly be a lot of, I think, moving pieces to this for sure. Public comment, I think, is always our friend. We need to do that more and especially represent, as Sarah mentioned, sort of the interest of our patients, but also think about how do we operationalize this, and are there going to be, you know, specific groups of people that we're going to struggle with. I think long-term care comes to mind with their sort of overall lower vaccination rates for their healthcare staff. Thankfully, we've got good vaccination rates for our residents in that setting, but there's always going to be a risk associated with that as well. So good question that came in on that. Looks like the next question that came in is, are there going to be continuing series on this topic if additional developments come out? Absolutely. So if there's more things that come out, Sarah and I will go ahead and get some more sessions scheduled to sort of break those down very similarly. The feedback so far has been good that you liked this sort of format of where we sort of took it very piecemeal and sort of took it apart individually. So we'll continue to use that approach unless anybody has any specific request. As well. So probably look for at least 1 or 2 invites in the month of October once we get a little bit more of a handle on what the actual proposed language will look like and sort of implementation as well. And it looks like the last question that came in is, how much jurisdiction does OSHA have on inspections and what are they using as a template? So excellent question. So on the OSHA ETS website, you can actually go down to the bottom right and there is actually a sort of enforcement guide. It's several pages. I think it's over 40 pages long, if I'm not mistaken. And it actually gives you not only the information that they're looking for, but sort of how they would do the inspection and what sort of the punitive impacts of those things could be. There also is, thankfully, in there something that says that OSHA enforcement agents have a lot of discretion, right? So if they feel like you're trying to do your best and you're making every effort that you can, and you simply haven't been able to do that particular piece, they do have sort of enforcement discretion. And again, this is the federal piece. So Sarah mentioned, your state inspectors may be a little bit different, but normally they'll sort of follow a lot of those same parameters. But I'm glad to see that there's discretion. It's just like if you get pulled over by a police officer and you really polite and smile and you were only going 2 miles over, hopefully they'll use discretion and say, have a great day, just slow down. So hopefully you'll see more of that and a little bit more of a consultative approach, but certainly would encourage us to monitor that stuff very detailed, especially when CMS is using words like we strongly encourage you to. That is normally a warning sign that more things are to come. So any other questions from the group? That's all that I saw in the chat. So Heather said, on the subject of reporting to OSHA for an employee hospitalization or death, that is done if the exposure or contracture of COVID was occupational. That's correct. Yeah, so if it's related to COVID-19, then it's going to be covered by the ETS. So you either have the 8 hours for the death or the 24 hours for the hospitalization. So excellent question, Heather.
And I believe that they clarified in the ETS that regardless of whether you deem it work-related, right, if it's a death and they're an employee and it's COVID,
right,
it needs to be reported.
Yeah.
So that takes some of the subjectivity out of it. So you don't have to decide, were they exposed here? Was there a family member? We're just reporting it all. And then they can go from there on the back end.
Other questions? Yes, Heather, it's the same. Okay. Sarah, do you see any questions in your chat? I don't see any more over here.
No.
Okay. All right. Well, we will send out the recording for today's session. We'll also provide an email with the handouts. As I mentioned, and I'll say one last time, your CE information, if you're a nurse, will come from Terry Goodman and Associates. So everybody will receive that link. So you can even create your own certificate there, even if you're not a nurse, just to have it for your files. But that will be coming out to you no later than close of business on Wednesday of this week. On behalf of Sarah, myself, and our whole team at CTEP, thanks so much for taking the time out of your busy day to join us for today's program. We hope you enjoyed it, and we look forward to seeing you again, probably in October. So take care and have a wonderful remainder of your week.